Hello everyone and welcome to Well Talks. I am Dr. Anvi Vaidia and joining us today is Dr. Suzanne Crandall. She is a neurologist at the St. Luke's Hospital in Kansas City, and we will be talking to her today about CVA, stroke, or as we call it, the cerebrovascular accidents. Let's go ahead and welcome Dr. Crandall.
Thanks,
Hello, Dr.
Anvi.
Crandall. How are you?
Thanks so much. I appreciate you having me.
Sure. Okay. Do you want to start with an introduction of yourself? Mine was pretty short, so I would love to hear from you.
So I'm Suzanne Crandall. I went to medical school here in Kansas City and graduated in 2005. And then did my neurology residency up in Michigan through the Michigan State University system. And I've been back here at St. Luke's Hospital of Kansas City and the other metro hospitals for almost 10 years.
Wow. Wow. That's amazing. We are going to talk to her today about CVA. So do you want to start with an idea of what that means? And,
Sure. So as a neurologist, I work both in the outpatient setting in the office and in the hospital. One of our bigger diagnoses that we take care of in the hospital would be stroke or CVA. And a stroke, for those of you who don't know, is a neurologic emergency. It's a neurologic event that we ascribe to reduced blood flow in the brain in a specific vascular pattern, so a specific artery that is not getting blood flow and nutrients to the brain.
Wow. So now, how do you differentiate that and TIA, the transient ischemic?
Sure. So that line has actually gotten a little bit more blurred over the last 5 years or so. So a transient ischemic attack used to be characterized as a reversible neurologic event, something that reversed itself within 24 hours. And now we call a TIA a neurologic event that is reversible, and there is no evidence of damage on imaging. Because we know in many cases people will have a stroke and have a rapid resolution of symptoms, but there will still be damage to the brain on MRI.
Wow. So delving into signs and symptoms, what would a patient present with, as in symptoms-wise? What would a patient present with to the ER or to wherever that he's presenting in terms of symptoms that would be significant?
So most commonly, people presenting with stroke will have a constellation of symptoms that reflect which arteries involved in the brain. So when we think about stroke, either from print media or what we see on television, the most common symptoms of stroke would include facial drooping, especially of the lower face, arm weakness, leg weakness. Sometimes people will present with vision loss in both eyes, difficulty speaking, slurred speech, or even difficulty getting words out or being unable to get words out. Those are probably the most common symptoms of stroke.
And then to differentiate or identify that this is a stroke, what should be a clinician looking for?
Sure. So when patients first go to the emergency department, which is what we recommend, if you see somebody who looks like they're having signs of stroke, we use a mnemonic that we call FAST. So we say face, arm, speech, and the T part is time to call 911. So patients should be seen at an emergency department. We look for this constellation of symptoms and say, gosh, face, arm, slurred speech, that makes me think that the patient may be having a stroke. So there are two major types of strokes. One of those is occlusion of a blood vessel without involvement of any bleeding in the brain. We call that an ischemic stroke. That makes up about 80% of total strokes. The other 20% are hemorrhagic strokes, which involve bleeding either inside the brain substance or around the brain substance. So opportunities for treatment really depend on which kind of stroke the patient's had. So the first test that we recommend in that case is a non-contrasted head CT scan.
Okay.
To look and see if we see any evidence of bleeding in the brain or if it looks like an ischemic stroke.
True. So then when we talk about diagnostics, you mentioned CT scan, you mentioned MRI. What would be some other diagnostic tests, including labs, that you would want to do?
Sure. So one of the great things about being involved with St. Luke's Hospital of Kansas City is that we are a comprehensive stroke center. All of the metro hospitals are primary stroke centers. So the emergency department nurses and physicians are really specially trained to look for stroke, and they have access to neurological services 24 hours a day. So the first diagnostic test we really do, besides a CT scan to make sure that there's not bleeding in the brain, is really a neurological examination, which tells me if I think the patient needs further imaging. And then after that, we do imaging that looks at the blood vessel system going from the heart all the way up into the head. We do laboratory studies to make sure that the patient's blood sugar is within the normal range, that the rest of their electrolytes are normal, and that they're not on blood thinning medications, which could make acute stroke intervention dangerous.
Oh, okay.
It's really important that we find out when patients were last known to be well. That's really the biggest piece of history I need, that somebody comes in and says, I know my dad was normal at dinner time because I saw him, and then something happened after that. And then to get a list of patients' medications.
Oh, okay. So what you're saying is for diagnosis, the most important would be some kind of imaging.
Some kind of imaging.
Okay, okay.
Right.
Then getting into treatment. What kind of treatments do we have available for stroke?
It's been very exciting to be a neurologist over the last 10 to 15 years with the new interventional therapies that we have for stroke. So the most important reason to know if the patient has any bleeding inside the brain is because the first intervention for stroke that came out is a clot-busting medication called tissue plasminogen activator, or TPA. And TPA is a medication administered intravenously to patients that we believe are having an ischemic stroke with symptoms beginning within 3 hours. In some circumstances, with symptoms beginning within the last 4.5 hours. Your only real contraindication to the use of this medication is bleeding within the brain, because in and of itself, it can cause or exacerbate bleeding. So that was the first news that came out for stroke, starting with research in 1993. And we were actually part of the original TPA trial.
Wow,
so kind of exciting to use as much of this medication as we do, and know that before it was FDA approved, it was being used experimentally.
Wow.
And then over the last 5 years, there's been a variety of different neurointerventional techniques used. Using cerebral arteriography, which is the use of small devices going up through a big artery in the groin to actually go up, capture this clot, and then try and pull it back. Corkscrew devices, aspiration or little vacuum devices, or little stent retrievers going through. That's been kind of a new horizon for stroke care over the last 5 years.
So when you say occlusion, when you say, that there is some kind of blood supply that is being compromised, is stenting an option? Stenting and...
So when patients have occlusion of one of the major arteries in the neck, in many cases you can do a procedure to get rid of that clot and then stent that artery open. Sometimes what we find is something's traveled from this occlusion in the neck up into the head that then the operator needs to go after and get that clot out. So they need to hold the vessel open with a stent. Stenting emergently within the intracranial vessels is not recommended. There was a large trial done about 8 years ago called the Sampras trial that found that in patients who had intracranial stenting, they were actually more likely to die than were patients who just had maximal medical therapy. We think part of that is because in some cases, if you take out an area of the vessel that's just narrowed and you put a stent in there, the vessel needs that framework in order to stay open. Right? So sometimes what we find is the interventionalist goes in, takes out this area of the vessel that seems to be narrowed, and then the vessel collapses. That framework that the vessel was sort of being hooked open using is gone. And if the stent reoccludes, the patient goes on to have a more devastating stroke. So in most cases, we do anything that we can do safely in terms of intervention, and then put the patient on maximal medical therapy and monitor them, obviously over a series of days in the hospital, but even over a series of months as outpatient. Patients who are failing maximal medical therapy, they're managing their blood pressure, they're managing lipids, their blood sugars, they stop smoking, and who are still having symptoms. In some cases, we can then work on stenting them as outpatients when their condition is not quite so emergent.
Wow, okay. And then when you talked about patients who maintain themselves after they get treatment mostly, how would you rate the prognosis for a stroke patient?
So stroke, kind of like heart attack, I know you had Dr. O'Keefe here a few weeks ago talking about myocardial infarction, is associated with other underlying medical conditions, right? Most people, the vast majority of people, will not have a stroke without the finding of some sort of risk factor for stroke. So when we think about risk factors for stroke, age is the number one risk factor, right? More elderly people have stroke than younger people. That doesn't mean that we don't see stroke even in children in some cases, usually for a different reason than older people. But high blood pressure, high cholesterol, diabetes is a major risk factor for stroke. Smoking is a real insult to all the vessels of the body and is a problem in terms of stroke. So as much as possible, we like to identify risk factors after we've treated somebody as much as we can with intervention. So sometimes we think about stroke care as almost being a triangle. So the top part is the intervention part, and then either corner on the bottom. One is rehabilitation, getting that patient working with physical therapy, occupational therapy, and speech, trying to make them as functional as possible. And then the other corner is trying to prevent them from having another stroke. So if you think about a patient who's had a stroke, they obviously have risk factors that are in place. And in many cases, those risk factors are not better, even a week, a month, even 6 months after they presented with stroke. So there is a risk that patients go on to have another stroke over the next 5 years. That's somewhere in the neighborhood of 6 to 14% in their first year, and then somewhere between 6 and 9% every year thereafter for 5 years.
Wow, that's great information. Absolutely. Finally, I would like to say to you, is there something that you would like to tell the students that must be watching us about stroke, something that they should be looking for, something that is really key in diagnosis, treatment, or anything that we have not talked about right now?
So at the same time, we don't really like to think about stroke happening in young people. We definitely see stroke in younger adults. Sometimes that's associated with things like hormonal contraception or even hormone use, testosterone supplementation, and other sorts of hormone boosters that in many cases you can buy at GNC or other health food stores are associated with what we call hypercoagulability, or an increased risk of blood clots in the leg, blood clots in the lung, heart attack, and stroke. And especially in women who are on hormonal contraception and who smoke, who are over 35, we know that their risk of stroke, heart attack, and blood clots in the leg and lung is increased. So those things should always be looked at in younger people, where you wonder why they may have had an event, to make sure that sometimes occult use of substances is not playing a role. And two, that your abilities to do a neurologic examination and recognize things that are wrong within the neurologic system will really clue you in on if your patient may be having a stroke. The symptoms that a patient has are really based on where the brain has been affected. So for example, things that affect vision back here in the back part of the brain, those patients are generally not weak. They're not weak. They don't have slurred speech. They're not always vertiginous. They don't have sensory problems. They really come in more with headache and blurry vision, or things look funny. And that, in fact, can be a stroke. And it's always it's difficult for us sometimes when we see somebody the next day that their stroke syndrome was not recognized because people were expected to be weak and they were not.
Oh, wow. So that is very interesting. It's great to hear about all of that we got to know right now about stroke. We read textbooks, we read literature and a lot of other stuff to get information, but when you get information directly from the person who sees patients and treats them on an everyday basis, that is really very valuable. So I would like to thank Dr. Crandall for taking the time to talk with us today about stroke and CVA. We hope to see you again with all these interesting topics and share your information with all of our students and viewers here.
That sounds great.
Thank you very much again.
You're so
welcome. And thank you everyone for watching us. Thank you.